This is the Behavioral Observations Podcast with Matt Sikoria, session number 46.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Hey everyone, it's Matt here. Welcome to session 46 of the Behavioral Observations Podcast. I am so excited to be joined today by Tim Courtney. Tim is the Chief Operating Officer of Little Star ABA, and he's also a nationally recognized expert on all things medical necessity. So we do talk quite a bit about that, and we also share some listener questions about this topic. It's a common pain point for folks in practice, and he gives us a little kind of tutorial on this sort of thing. So we also talk about their unique model for supervision. It's the apprenticeship model, which I think is pretty neat. And finally, we get into a little tangent, if you will, on men's fashion. Yep, that's right. You're listening to the correct podcast here. We did take a little detour. Tim is not only a national expert on medical necessity, but he's also very well known for being a snappy dresser. So he answers some pretty, I guess, selfish questions on my part, where he is known for this sort of thing. I am the non-example, if you will. So he takes a few minutes to help a brother out. So for the fellas out there, you might want to stay to the very end to catch that. So we had a fun conversation. We left so many items on the table as well that we are definitely planning a second interview. So if there are things that we brought up that you want to hear more about, feel free to let me know. You can comment on social media, or you can reach out to me at behavioralobservations.com/contact. So second thing I want to mention is I want to thank you guys so much for all of you who took a few minutes to answer the second annual Behavioral Observations Podcast listener survey. We are over 500,000 downloads. We have about 520,000 downloads right now since we've been doing this for 2 years. As a matter of fact, last week was our kind of 2-year anniversary of publishing session number 1, which is one of the most popular episodes. And it's been a great experience for me. I've met hundreds and hundreds of people. I've learned so much from guests and things like that. It's been great fun. And so with this listener survey, I got a lot of great feedback about how to improve the podcast, on how to incorporate topics that are more relevant to you as a listener, and certainly great suggestions for future guests. So I don't think we're going to run out of any topics anytime soon. So again, for you guys, it took a few minutes to fill that out. We got almost 250 responses, which I was completely blown away by. Again, I just want to say thanks so much. And before we get to the interview itself, this podcast is sponsored by Operant Coffee and Chartlytics. Let's talk about Operant Coffee for a minute. We've been chatting about these guys in the last few episodes. This is the brainchild of Beth Garrison, and she kind of put her money where her mouth is. She's using ABA principles in a decidedly non-ABA field, or market, if you will, of selling coffee. Probably one of the, which has been happening forever. But they're using behavior analysis to foster sustainable business practices and other sorts of things like that. It doesn't hurt that the coffee is fantastic. So if you want to try it out, go to operantcoffee.com, order yourself a bag of the Burris Breakfast Blend, and you can see what all the fuss is about. And if you want to save a few bucks while you're at it, use the coupon code BehaviorCoffee, all one word, all caps. Last but not least, let's talk about Chartlytics for a minute. We've been talking about Chartlytics in the context of a lot of their training opportunities. I attended a 2-day precision teaching workshop, and I've got a couple more coming up. There's one coming up in Connecticut in April, and another in the Pensacola, Florida area in June. But what I've been kind of playing around with more recently is their software. I've been using the Chartlytics web application, I guess. I don't know. These guys can correct me if it's not the correct term. But we've been using that to actually do some charting. So in addition to learning about precision teaching, you can use Chartlytics technological innovations to do the business of charting on a standard acceleration chart. And that's been a ton of fun to kind of play around with. I've been charting, I guess, to use air quotes, conventionally for almost 20 years now. And it's been really fun to, challenge your data assumptions and challenge your practices and things like that. I think that's something, whether you agree with using the standard acceleration chart or not, it's fun to kind of look at things from a different perspective and at least ask the question why you're doing what you're doing and things like that. So it's been great fun diving into this new type of measurement science for me. So it's been, like I said, great fun. If you want to learn more about this stuff, you can go to chartlytics.com/Matt. There is a free webinar there that is good for one CEU. There's a free ebook on precision teaching, and there's coupon codes for other things that they do, whether it's the workshops that I just mentioned. They also have a cool program called the Ambassador Program. And what that is basically for a monthly fee, you get access to the software. You get actual coaching from the charting ninjas at Chartlytics. It's really cool, and I've started that process as well. And so I'm hoping to be a charting ninja or maybe Padawan status, if we're going to use Star Wars terms, in the near future. So again, go to chartlytics.com, and especially chartlytics.com/Matt for more info. So that's it for opening remarks. So without any further ado, please enjoy this wide-ranging conversation with Tim Courtney. Tim Courtney, welcome to the Behavioral Observations Podcast. How are you doing today?
I am doing fabulous, Matt. I am super excited to be on the Behavior Observations Podcast. Thanks so much for setting this up.
Well, I think the thanks goes to none other than Dr. Megan Miller, who basically forced us to do this. For those folks at home listening, Megan is like my job coach. When I go to conferences, she always is like having me meet this, that, and the other person, and giving me prompts for social cues, like introduce yourself, shake their hands, look them in the eye, things like that.
You're in fabulous hands. She's a really powerful networker and has a wonderful vision for great connections and partnerships. I mean, I think she has a wonderful vision. So
yes, I've she's the unofficial producer of the show, apparently, and. So again, for those of you guys listening, she basically emailed both of us and basically said, "Guys, get it together and do this show." And so here we are.
Yeah, you didn't have to twist my heart at all. I mean, you've had an impressive audience. I mean, this podcast is really great.
Thanks, I appreciate that, and it's because we get great guests and talk about what I think are fun topics, and we're going to talk about a couple of those fun topics today, mainly supervision and medical necessity and fun things like that. Particularly the latter is something I don't know a lot about because I work primarily in school. So I'm looking forward to learning a lot today. So one of the things that we chatted about when we were talking about this podcast a while back is that you and I are, I think, around the same age. And so I wonder if you could tell me a little bit about your experiences coming into the field as a young man, and kind of how it's different today. And you are the chief operating officer of Little Star, and so if you can tell us a little bit about what you're doing there as well, that would be great. That'd be a good place to start.
Yeah. The environment definitely selected my behavior as I kind of moved into the field of behavior analysis. It's interesting as I look back across my story, just how things kind of fell into place. I mean, it really started from a chance encounter. I was leaving the gym. There was a guy that I knew, he was going in the gym. I knew him from high school, and I kind of talked to him about, kind of work he was doing, talked to him about what I was doing at the time. I was investigating child abuse for the state of Florida, and not really loving that work, but it was important work. And he talked about behavior analysis, and he was doing some consulting, and his name's Isidro Zavaleta. He owns a company called Coastal Behavioral Therapy in Florida, Melbourne, Florida. And so he was describing what he was doing. I'm like, oh, that sounds amazing. Like stuff I've always loved, blending science and effectiveness and, helping helping individuals through some challenging times. And so he kind of explained the process. And at the time it was, different. You could kind of get your BCABA or BCBA through just these courses that were being offered kind of throughout the country. And I was real fortunate. There was a guy, Andrew Hooverus, super lucky to connect with him. He helped me to get to meet the BCABA criteria, and I was instantly just in love with behavior analysis. So quickly after that, enrolled in FIT and got my master's completed, got my BCBA. While I was doing that, I was actually doing similar work like what you're doing now. I had the opportunity to work as a behavior consultant for the Brevard County Public Schools, and that was a really neat experience as I was working towards certification. I had opportunity to work at Devereaux, doing residential treatment in Florida. So had a really neat experience there. Then once I completed my master's, kind of went out and started doing some work in the community. So I was able to work with group homes and working with adults and working with children as well. So I had, really had an opportunity to work in lots of different settings as a behavior analyst. Then shifted gears and had this opportunity at Little Star. When I came into Little Star initially, I was the only clinical director. We had maybe 10 or so staff when I kind of first started. We're up over 300 staff now. And I quickly found, like, I really love the clinical work, really, really love the clinical work. But what I also really love is being able to create systems so that we can so lots of people can access this powerful and amazing therapy that we really the most proven, most effective therapy for individuals with autism. And we, having the opportunity to get this and be able to reach as many kids as possible and develop systems where we can maximize resources and be able to really harness this and get this therapy out to a lot of people was something I was like, oh, I love this. And I kind of was dragged kicking and screaming out of doing the clinical work. But then I was like, oh, this is what I want to do forever is work on the system side, the operations side, and just really kind of nerd out on how to create these systems that allow us to do really effective therapy. As part of that was this insurance piece. So we were really thrusted into having this knowledge about insurance and medical necessity, and which was a piece that it wasn't touched on in my coursework, wasn't touched on in my supervision or my experience prior to this. And so really having to learn that and really get to understand that very well is something that I really have had to spend quite a bit of time over the last couple of years focusing on.
Well, I want to dig into that more, but I also don't want to skip over, you mentioned Little Star, but for those who aren't familiar with the organization, tell us a little bit about it.
Yeah. So Little Star ABA Therapy, we are in Indiana. And Indiana will be significant to this discussion because Indiana was the first state to have an insurance mandate. So we're really all the states that have followed suit now through the efforts of Autism Speak and the Autism Speaks and the amazing things they're doing. And some of the advocacy efforts by parents across the country. I mean, it's been an amazing process to see these insurance mandates continue to evolve. But we really were the first state, and there were several years, 6 years, where we were practicing and other states didn't have a mandate. So we've had kind of a head start in a way to get to kind of understand the system. But Little Star, we're a combination of center-based and in-home programming, about 90% center-based. We have centers across the state, which is another kind of interesting point for this discussion today, setting up systems that can scale out and kind of we have sites that are throughout the state. We're in Lafayette, Indiana, and Bloomington, Indiana, Newburgh, and Clarksville, Indiana, and our main site's in Carmel. So it's kind of our hub where all of our administrative services, and that's where I'm at. It's where I'm broadcasting from today. So is in beautiful Carmel, Indiana.
I see. Very cool. Was it hard to? You said you were drag kicking and screaming out of the clinical work. What would you say would be what was the hardest thing about leaving that aspect of service delivery?
Yeah, I mean, I in envisioning kind of my career path, and I wanted to be like some of the other guests that you've had on, Wayne Fisher and Greg Hanley, and these guys that are just brilliant clinicians and just really have found a way to understand these complex areas and really diving in and taking a deep dive into functional analysis and exploring really all of those clinical stuff. That was really what I was radical on the clinical side, and that's just what I envisioned doing. So shifting gears to operations and logistics and systems and, finances and insurance and all of this stuff that I was like, wow, I mean, but what was beautiful is having this behavior analytic approach. It's so effective in multiple different problems. Really, any problem you have this behavior analytic approach, I found like I'm just well equipped and likely better equipped than others that might have a better business acumen or some other kind of training, but not having this behavior analytic piece. I feel like it's kind of my superpower is to be able to approach all of these situations, and behavior analysis just continues to have the solutions and kind of drive a lot of the answers.
Cool. Now, one question that just kind of occurred to me was, as behavior analysts kind of develop in their career and go from not having a lot of, going from having a lot of direct contact with learners and consumers and what have you, to transitioning into a role like yours, where you're, kind of, again, as you say, on the operations side. How do you manage to, if you're providing supervision and things like that, what are some ways in which you've found to kind of keep your clinical skills sharp as you're spending more and more time with the spreadsheets and less time, on the floor?
Yeah. And to be honest, there is some give and take there. I mean, you kind of realize that, hey, I'm going to further develop on this side, and I'm going to surround myself and I'm going to lean on people that have that clinical expertise. And I'm going to, we have amazing clinical directors at Little Star and program managers. So that's our entry level BCBAs. Clinical directors are their supervisors, senior clinical directors, Dr. Brianne Hartley, Vince LaMarca. I mean, these really brilliant kind of people that I lean on heavy for the clinical part, and, realize that, hey, I'm giving up some of that. That dream that I had was, focused on doing that. Instead, I'm diving into leadership areas and really trying to explore and kind of understand leadership more. And currently working on my PhD at Benedictine University on leadership, and kind of realizing that, hey, this is my focus. I want to move further and further in operations, but I'm just going to surround myself. I'm going to have a team and expertise in those areas, and realizing that I'm not going to be the smartest clinical person in the room. And there could be absolutely, and hoping that junior members on my team are maybe even more adept clinically than I am. But when it comes to operations and structure and logistics, that's a piece that I will continue to dive into, and not expect them to have to give up a lot of their clinical expertise to understand more of the operations part. And I think this is, so for people that are, kind of going into the field, you're kind of starting as a behavior analyst. And I think a lot of people are almost kind of want to start their own programs or start their, coming right out of graduate school, and you want to dive right into this. And, I would really, really strongly encourage them to develop the clinical part, spend lots of time on the clinical, have mentorship and expertise that you can kind of look to on the logistics operation side, having, people that really understand that well, being able to learn and understand from them, and then, shift over and kind of move into those leadership positions. And with this, realize, because and we hear it a lot from people that go from our entry level BCBA role, which is the program manager role. We want to move them into clinical director roles. And a lot of times they're like, oh, I want to keep clinically. I want to keep working with kids. I don't want to stop working with kids. But like I said, you shift into this role where you're creating situations and systems where you can affect more kids. And, that's really my goal now, is I want to make sure we're 150, 200, however many kids, that we're able to reach all of them with good, effective, amazing therapy, and having, the clinical expertise there to be able to reach that. But outside of that, I definitely still stay in the literature, read the literature. I stay active in research. I'll definitely jump in and help on clinical research projects. Just published a study with, Matt Broadhead in JABA, and doing some of that area. And so a lot of times we're doing a lot of the, still even on the logistics, leadership areas, we did an apprenticeship model that I think we're going to dive into more, and we published that in Behavior Analysis and Practice. So still staying active research. I also am a co-instructor for Florida Institute of Technology. So that forces me to kind of stay clinical and stay sharp there and make sure I have a solid understanding of the behavioral principles. but that's some of the ways that and definitely going to conferences. I still love just going to clinical presentations, symposiums, hearing from people like other guests you've had, or, even grad students and some of the cool kind of work that they're doing to continue to push our science in a lot of ways. And knowing that I need to have a solid understanding of that so that we can bring some of that back to the clinical services that we're providing. That's what's also wonderful about being kind of an expert leader, because already having knowledge of behavior analysis moving into leadership versus somebody that just had a business degree and didn't have the behavior analytic part. I can have a solid understanding. I can consume our science. I can consume the literature. I can consume symposium, be able to kind of work on how do we bring that home? How do we create systems so that we can now do that here?
I see. Yeah, and you can go back to Indiana to your clinical teams. Hey, you gotta check this out, guys. I just saw this at APBA or
and at a higher level. This is how we're going to make sure we do this. Let's prototype it. Let's test it out. Let's see how that works. And okay, that works. Let's start working on scaling and creating teams that focus on scaling out and moving those things forward. Versus a lot of times you'll go and you'll attend these amazing talks and you'll bring that knowledge back to it, maybe a single case, and then, it gets diffused, or, maybe you'll add that to your repertoire as a clinician. But what's cool is to try to create systems where you can add it to the repertoire of all your clinicians and to your teams. And then they can kind of create systems so that is then passed on to others as they're coming on, and you can affect, multiple different BCBAs.
I know the scaling aspect is not necessarily the focal point of our conversation today, but is there at least just one example you can share about how you make sure, say, a particular intervention strategy or whatever gets disseminated across your clinical team, or just any other type of example of how you ensure kind of a consistent approach, given that you've got so many people working for you? And working with you,
it might be a wonderful additional time for us to chat.
Sure. We could tee it up for round two, but if there's a quick story that you have, by all means, indulge us.
Yeah. I mean, we have this amazing scorecard system that was developed by Aubrey Daniels International. So, so through the scorecard system, we use that as a way to kind of ensure high degrees of fidelity. So you kind of pinpoint, you go through the process, and for each of the different positions, we're pinpointing what are key measures of performance. And so that allows us, so let's say we found like this new clinical procedure, we could go to our scorecard system and modify pinpoints. And now that becomes the expectation across the board. So after we prototype something, we find some teaching procedure that, some different way that we want to modify an errorless procedure. So we go in now and we're going to modify that, create data sheets that this is how it's observed. This is how we're training apprentices on how to do it. This is how apprentices are training technicians on how to do it. And then it gets rolled into everybody's scorecard, and you can use the scorecard, and monthly. It's monthly scorecard for all of our clinical people, and pretty soon all of our admin. It's tied to incentives as well. So every month you get an incentive bonus up to 5% of your base pay is paid out in an incentive that's tied directly to your performance. So that's been our key strategy for ensuring a high degree of fidelity, ensuring that we can kind of spread out these interventions as we prototype, found something that's worked, and we want to add it into the system.
Awesome. Well, that's a perfect tease, I guess, for perhaps a subsequent discussion. I'm sure we'll get lots of questions on that. So
dive into it. It's been a ton of fun working with them. We learned it was the late Bill Abernathy. He kind of helped us initially start it, which was just amazing. His expertise on, performance design, and so it was it's been a tremendous opportunity. We're in the evolution phase, so there's some fun stories and some challenges and some things that have been going on as we've been moving into integrating that system. But I think it would be a really fun talk for us to chat about it at another time.
All right, excellent. So let's get into, let's talk about medical necessity, and then we'll talk about supervision if time permits. And so for people like me who are blissfully ignorant, can you just kind of get us all on the same page in terms of terminology? So
Sure.
Talk about what medical necessity is to those of us who aren't aware of it. and talk about, and then we can kind of expand the conversation from there. But let's just start by getting us all on the same page as it relates
Yeah.
to terminology.
I think a lot of ways, so for everybody, even if you're not working in the field of autism, right? It's significant if you're working in autism, this idea of medical necessity. But even for all of us, we work with our primary care physicians, right? So you'll go into your primary care physician and you have, you feel like you're getting some flu symptoms or something, right? So you're meeting with your primary care physician. He's going to have to justify the treatments and things that he's doing, that he's recommending. That's all going to have to be justified as being medically necessary in order to be able to bill for and provide assurances under the insurance company. He has kind of a contract or an agreement with an insurance company that here's the services I'm going to provide, and here's what I'm addressing. And that's why so if you go to I don't know if everybody encounters this, but I go to an optometrist and the eye doctor is telling me, hey, we have this really cool machine. It'll do this neat x-ray of your eye, but you'll have to pay for it out of pocket, right? So what they're saying is we can't prove that it's medically necessary. So my comment always to them is, why isn't it medically necessary? Why aren't you appealing or proving to the insurance companies that this x-ray of my eye is medically necessary? I mean, you're explaining it to me. You're saying, hey, we're going to use this to compare and see how things are kind of going on in the future. Well, why? If they're not going to pay for it, I'm not going to pay for it. You know what I mean? If you can't prove that it's medically necessary, I'm not going to prove it. So what we're doing in the autism space, though, is we're proving that the treatment that we're providing, the goals and areas that we're targeting, are directly tied to the autism diagnosis. And this is something that that we kind of stumbled upon in developing this system. So like I said, I was dragged kind of kicking and screaming and forced kind of overnight. Like we were almost going to go out of business because of for a while, there was no problem working with insurance companies. They were just kind of, we were submitting treatment plans. Everything was getting approved. No problems, right? We were having just zero issues. And pretty much overnight, everything started to get scrutinized. And, hours are getting cut and reduced, and learners are getting just their entire program denied, overnight. And so it was like, what in the world is going on? And there suddenly became this high level of scrutiny of medical necessity. And so we had to quickly kind of get an understanding of, and working with medical reviewers, we work with a lot of different insurance companies. And so working with the medical reviewer, that's person who works for the insurance company, and they're evaluating your treatment plan, evaluating it for medical necessity criteria. Just that's the whole goal of what they're supposed to be doing is, does the treatment plan you're submitted, does it show adequate progress, and does it prove medical necessity? Right? Those are the two pieces that you're supposed to be doing with a treatment plan, and that they're supposed to be evaluating whether or not it does it. So working with this medical reviewer, and lots of discussion and debates, and and I was like, hey, can you really help me with this medical necessity area? Like let's get this agreement. I know it's really hard for you. It's really hard for us. How can we come to some agreement as to what is the definition of medical necessity? And she pushed back to me and she's like, that's for you to define for us. And I was like, I don't know how helpful that is, right? I mean, it's just this semantic loop of, they could say, well, that's not medically necessary. And it was very circular. Why is it a medical necessary? Because it's not tied to the diagnosis, so you had this, this real challenge in regards to what is medical necessity. But I was able to pin her down. I said, hey, if it's in the DSM-5, right, is that fair? So if we're targeting areas that are in the DSM-5, will that prove medical necessity regarding the autism diagnosis? She said yes, right? So from there, we started structuring where all of our treatment plans, every goal, every area that we're in has to be connected or tied to some symptom, and more importantly, some impairment area of autism, right? So not just a symptom, but how this symptom is impairing the individual. And through that impairment area, we will target kind of goals that are directly tied to the DSM. And it'll be directly tied to their initial diagnostic report, observations that we've had of symptoms and impairment areas, observation of the parents. All of those pieces are connected. And we do these all-day workshops on how to do this, so it's kind of hard to synthesize it into and to our short time that we have today. But there is this, the main goal is trying to make sure that you're proving that services are medically necessary, and proving that you're making adequate progress.
I see. And that's certainly a difference. as it relates to how at least behavioral consultation was done, several years ago, especially in school settings, whereas, people like us would go in and would, well, how long is this going to take? Well, I don't know, if you're doing an FBA or something like that, I'm like, well, I don't know. That just depends on, fill in the blank and things like that. So it sounds like a whole nother level of scrutiny and accountability also.
Yeah. And we're developing a specialty in autism. That's why, you have this amazing general skills as a behavior analyst, right? But definitely, I feel like if you want to work in autism, you're developing a specialization. And within this specialization, you need to truly understand the diagnosis. You need to really understand how do you get at symptoms impairments, understand the ADOS and Vineland, and a lot of tools that as behavior analysts, we typically wouldn't spend a lot of time on. I vividly remember going through coursework and being like, DSM-5 is not something we have to worry about, right? The DSM, it wasn't the 5 at the time, I think 4 or 3, but it's not something that we, and it's almost like it's mentalistic, like you're going to turn into a mentalist if you really dive into this book, right? It's not, but that's absolutely not the game. When you're moving into this specialization in autism, the DSM criteria is something you have to thoroughly understand. You have to thoroughly understand the autism diagnosis, thoroughly understand all of the symptom areas. What are those impairments? And then what you're targeting needs to relate to that in some way. And if you're targeting something else, it's not medically necessary and it shouldn't be billed or authorized under a treatment plan.
So, like you said, you do a lot of training on this, and you go around the country. You're, kind of one of the experts in this particular domain, if you will. What are the responses that you're seeing from the participants in your workshops? Or is it kind of like light dawning, or are there aha moments and things? I have to imagine that, if you can help people kind of crack that code, that probably relieves a lot of stress on their behalf.
At Little Star, I'm really fortunate. Little Star is a nonprofit, and we're really committed to this because what we see that we're doing through our advocacy work here is that we are really advocating for best practices, advocating for industry standards, right? So if we can make sure that people throughout the country are knowing how to work with insurance companies, knowing how to understanding this medical necessity process and doing good work where they defend and can recommend and advocate for the appropriate level of intensity for the services that they're recommending, and not just bowing down to the insurance companies and not really providing the correct level of support, and individuals aren't getting the level of service that they should be providing. We run the risk of the industry standard shifting in a way to where suddenly, if you're going to work in the autism space, you can only do 10 hours of therapy for anybody, right? No matter how intense the diagnosis, no matter how comprehensive the issues are that you need to address. But for sure, so the treatment planning workshops that we've done, these all-day workshops, and we'll do where there's one where it's just focused on the treatment plan and working with insurance companies. We get in the weeds on authorizations and a lot of stuff that it's not sexy at all, right? It's definitely not kind of work, and but it's the important work. Like, you can't do any of the sexy stuff that your other guests have kind of talked about. You can't do any of that if you can't get it, if you can't bill for it, if you can't fund it, if you can't support it. So being able to understand this and do this has become an absolute necessity. And I see the pain that people are going through in working with insurance companies. And it's all pain that we've already been exposed to. So if I can just give them strategies so they can access some negative reinforcement from that and strengthen instead really key behaviors so that they are doing really good kind of effective work on this space. It's absolutely been a powerful reinforcer. And we totally see it. We can see the light bulb moments where people are like, okay, now that I'm done with this, I am absolutely not going to just go with this suggestion from the insurance companies that they shouldn't be doing. They shouldn't be making clinical recommendations. So I am going to say, nope, this is my recommendation. This is how I came up with it. This is the process I'm going to do to stand by it. And if you deny it, I'll go through the appeal process, which we also train them on how to do the appeals and kind of all of that area as well. So it's interesting kind of throughout the country. We've done trainings in California and Alabama recently. We went to Alabama. Alabama just has a insurance mandate, and Autism Speaks, Mike Wasmer and others from Autism Speaks asked us, hey, can you come down and do this treatment planning workshop? Because they're just getting the insurance mandate there. So being able to go in and I mean, that's super fun work to go in where an insurance mandate is just starting. We did the same thing in Louisiana and just really helping with the basics and showing how just a lot of these kind of basics, foundational pieces are so important for people to have, and where they're, just, you don't get it in supervision, you don't get it in coursework. So being able to give people that skill set has really been super reinforcing for me, just to kind of be out and go and help people in this way.
Awesome. One of the things I was thinking of as you were talking about that is, what is the relationship that you have with various insurance providers? In other words, do they see I have to imagine there's a fair amount of education that's involved as you're talking to providers that perhaps aren't as familiar with autism and, more importantly, behavior analysis. And is it the case that once they understand the rationale for what you're asking for, that getting things green lighted is more likely to occur?
I think it's so when we initially started trying to figure this out, I was taking every phone call with the insurance company. I did every single one of them, right? And you can see me in video now. You can see I have this bald head. I always tell the story, like I had these beautiful flowing kind of locks of hair that were just all pulled out through that time frame of dealing with those phone calls. Because so our process was, and this is a process that we kind of continue with, but we've gotten to a level now where our system stays pretty standard, but we would do these experiments. Like, so you'd get some feedback from the insurance company, you'd experiment with, okay, we're going to try doing it this way and changing our system a little bit. And then we'd get feedback on, okay, that's not right. And I'd have to go back to the team. Okay, now we got to do it this way. And they're like, you just told us to do it just the exact opposite way last week. But that's the kind of the feedback loop that we were working through. And so I initially, in my relationships, I was trying to have this like educational partnership, wanted to be really kind of friendly and develop these, I thought it would be important to develop these ties, these connections with the medical directors, et cetera. But quickly found out that that's just not the strategy. I mean, really the strategy is to go in. This is how we came up with these interpretations, with our recommendations. This is the process. This is why we feel it's medically necessary. This is how we're making adequate progress. And, just listen to their discussions and, letting them know that we'll appeal. I mean, we'll go through the process. We understand our rights here. Sharing and being able to ask some questions that might get at potentially some legal issues with some of the suggestions and recommendations that they may or may not be making. And that's something I've been really fortunate through going to the Autism Law Summit every year. So I would really encourage all your listeners to go to the Law Summit. I mean, it's a wonderful way to kind of get a connection with what's going on with legally kind of across the country. And Dan Unum he's in the process of developing a national autism legal resource center. And he and I are actually going to start doing some talks kind of across the country where it's going to be the legal side and the clinical side. So we can kind of talk about, here's legal support for what you're doing, and here's the clinical kind of rationale and support, and kind of have this really pretty in-depth understanding of how both of those systems kind of work together. So we're, if people go to the Little Star website, you'll see kind of links on how to track us down for some of those talks, but we're gonna start doing those kind of across the country.
Neat. We'll certainly put the Little Star website in the show notes for this episode. So it sounds like some really kind of like an ongoing experiment of how to interact with these companies. Certainly. But
I do think just kind of working through a system that you feel confident in, that you guys that within your own system you have a level of scrutiny that's already going on. You are truly looking at treatment plans. We have different steps. We have the clinical directors looking at what the program manager submitted, and they're looking and seeing, hey, are all of these tied to symptoms? Are they tied to impairment areas? Are they related to the medical diagnosis? Are they educational? Because there is a line there for us. I mean, we can't target educational areas. If things are educational, then they fall under what needs to be met through through the education side, and we have to be on the on the medical side. So through that line, when we're looking to see, making sure all the goals are directly tied to that we are remediating some symptom or impairment through all aspects of the treatment plan.
So does that mean that you're leaving some skills that you would prefer to target out of intervention, or is it a matter of defining those skills in such a way that they meet this concept of medical necessity that you're describing here?
No, yeah, so no matter what, if there is an area, symptom impairment area that you need to get at, but you have to create some other kind of context, or there's some other kind of tools that you need to use to get at that, then absolutely we still target and kind of go forward. But the goal, the actual essence of what we're working on and what we're remediating has to be tied to a symptom or an impairment area.
All right, got it. All right, so the listeners have chimed in with some questions related to medical necessity. So let me ask some of those, and then we can talk about supervision. So
that's a really cool I got a chance to kind of screen that a little bit. So on your Facebook page, if you're a member, you get access to kind of give suggestions for questions and stuff.
Yeah, the Behavioral Observations podcast group is. And I put that on I kind of cross post them on the page and the group, so it gets out there, and I also put it on Twitter as well. So it's been a fun thing to do to get questions directly from the audience. It's one of my favorite aspects of the show. I also questions. Yeah, I know. Yeah. So let's see. These are two questions, but I think they pretty much address the same thing. One from David McKee and Dr. Becca Tagg from the Business of Behavior podcast. So let's see. This has to do with concerning the medical necessity model. We were recently given the template to follow for treatment plans, which only addresses 2 symptoms of autism: communication/social and fixed interests or activities. As with any medical diagnosis, if your treatment plan is effective, you will see a reduction in symptoms that accompany the diagnosis. The bigger concern for me is that the template does not address challenging behaviors, for example, physical aggression, self-injury, etc. This may be because they are not deemed symptoms of autism, but regardless, the funding source is not going to cover the cost of an FBA and behavior plan. If these are to be done, the provider will have to eat the cost. We know as BCBAs, these steps will have to be taken, but not in the 6 hours allotted by the new template. And let's see, just kind of summarize this here. So, so those are the ones I was, So what is, and if you can talk about the template as well, for those who aren't familiar with that, so what would you say about, some of those things that are outside of the diagnosis? Yeah.
I'll introduce a kind of a law or a rule that those that are in the space and those that have been in our workshops will hear us kind of talk about kind of regularly, is the Mental Health Parity and Addictions Equity Act. So MHPAEA is the, and this act really sets some rules and expectations for how insurance companies, have to approach, however they're approaching things on the physical side. So really working through this, like I said, when you go to your primary care doctor, et cetera, how you primarily address things on the physical side, you have to do the same thing on the mental health and addiction side as well, right? So you can't treat, just because you're on the mental health side, you can't treat this client population different. You can't have different expectations. You can't quantify things differently. So they talk about quantitative and non-quantitative. And this is getting into a very legal piece that really Dan Unum is an expert on. And he's the one I just look to him to kind of talk into this in detail. But the main point is, especially tied to this, is you can't put this non-quantitative treatment limitation to say, hey, you have to put your treatment plan in this template. Right? So unless on the majority, it can't be just a small subset. It has to be significant on the physical side that they do the same thing, right? So first of all, I would ask that. So do you require this template of everybody on the physical side? And the answer is going to be no, right? They don't. So I would say we have a treatment plan. Our treatment plan is what we see that gets all the areas under medical necessity. This is the treatment plan. And our treatment plan includes a decel area. And in the decel targets, we're talking about and tying in still how communication and other impairment areas are resulting in the occurrence of problem behavior, right? And so still can show and prove that they are medically necessary for us to address. We never get pushback from insurance companies on decel, right? It almost is the expectation that that's all we kind of do is decel. It's usually acquisition stuff that we have to really spend a lot of time trying to prove, but on the decel side, so just because for one, I would really push back. I'm not going to use your template. I'll attach our treatment plan to your template. You can kind of still review the treatment plan that we've had other funding sources, other insurance companies have similar requirements, and we just attach our treatment plan to the template, and it's and then still make sure within that other area that we are addressing the decel if decel is appropriate.
I see. All right, cool.
The other portion of their so there are T codes, and the insurance on the ABA side, or I'm sorry, on the insurance side, ABA is in process, and it's seems to be kind of coming to a head where we're going to have these permanent billing codes. Right now we're using temporary billing codes, and before that we were borrowing billing codes from other disciplines, right? And so mainly from psychology, and we were just trying to force them to the type of services that we were providing. So that gave the insurance companies a lot of leeway to kind of put unique expectations on the different codes and unique requirements. And so as we get these permanent codes coming out, there are codes that allow for functional assessment and allow you to kind of get authorized for that. And there are some that allow you to have 2 technicians while you're doing functional analysis. So there are codes that you can use currently. So I know there was some discussion about not being able to use codes to bill for functional assessment. So there are currently CPT codes that allow for that. And then the permanent codes, hopefully I'm under the impression that they're also going to kind of allow for that. So.
All right, cool. Sean Peterson asks, I would like to hear Tim's take on developing the duration of hours to be delivered. It cannot be based solely on number of skills, so how does he weight skills and determine what he's going to request? As a second question, when required to include the discharge criteria from the first assessment, what does Tim include? I struggle to know how much progress a child might make in 3 to 6 months and hate when he can't make 50% of goals, even when progress is being made and shown.
Yeah, this is a fabulous question. And then this really highlights, these are the kind of questions and pain points that providers, like you asked about earlier, like as we're going across the country, I mean, this is a good summary of the kind of pain points that behavior analysts are having kind of across the country as they're trying to figure out what's the best way to prove medical necessity and to kind of work within the system and do the good level of effective work that we do. So that first part, so in the duration side, we often talk about that as intensity, right? So it's the kind of the dosage of treatment. You know, this is the recommended hours that you're going to put forth to each of your different goals. And so what we do, our process, and this is the process that we work through at our workshop. And what I can do through your show notes is I'll share with you a tool that we use that helps to calculate intensity, right? So it'll be a tool that you can share with your listeners, one that we kind of work through in our workshops. But the goal is to create all of your goal and objective areas initially. So that's the first part. Create all your goals and objectives. And then based on all your goals and objectives, you start to use your clinical knowledge. Okay, typically working on this target area, these are all the targets that I'm going to have to work on to be able to achieve this goal. And these targets, I'm going to need a technician spending X amount of time per day. And then that's going to result in X amount per week, right? And then it's going to take this many weeks or to be able to achieve the goal area. So you're kind of calculating, and you ultimately run all that math, and you'll determine the intensity of service. This is the intensity that we're recommending. what's really important is the intensity recommendation cannot be driven by availability, right? So you have this learner available from 8:30 to 4:30 or from 9 to 5 Monday through Friday. So I'm just going to fill his time with goal areas that we can do. It should not be, your determination should never be based on availability. It should be based on what level, what intensity of treatment's required so that you can meet the goal areas, which would tie to the subsequent. So the second question is really an interesting one. So it's about, so when we're initially creating our treatment plans, and the listeners, right? I mean, this is a really challenging kind of thing, is to throw a dart as to saying, based on here are the symptom impairment areas, here are the target and goals that we're initially going at. I think we can achieve in 6 months this percentage of them, right? So, or these are the goals that I think we can reach in 6 months. And we've definitely, the insurance companies understand, hey, we're calibrating that, so our first time we set that, we're going to probably be off, right? And we might be off by as much as 50%. We definitely see times where we're off and we hit 50%, but we're going to get better calibrated as we have subsequent authorizations, right? So we should get better and better at saying, okay, now we know this learner's acquisition profile, how they're acquiring skills. So we have a better understanding of this next time frame. Here are the goals that we're going to meet. And this is also an area for the program managers where what they're saying they're going to meet, they over the 6 month period, they say, hey, this is what we're going to do in 6 months. So each month they then say, okay, to get here in 6 months, this is what I have to reach this month, right? So at the beginning of the month, they'll meet with their supervisor and say, okay, here's my treatment plans. This is what I need to achieve by the end of the month if I'm still going to reach 100% of those by the end of the 6 months, right? And so they then submit that to the scorecard system, and the scorecard is evaluating, okay, you said you were, this is what you need to achieve this month. What percentage did you achieve, right? So it can be really hard on the 6 month, but if you can scale that back, okay, what am I going to do this month? And what do I need to do next month so that I can keep mapping that out? So, and if you get off track 1 month early in the authorization period, you still have several months to get back on track, right? Where historically, our system was not always this way. It used to be the case where, it'd be the end, they're like, oh my gosh, I'm at 30% of my goals. What can I do? It's the end of the authorization period. There's nothing that can be done. I mean, we're gonna have to submit that. And it's another concerning point when you're submitting your treatment plans, and because when you for subsequent authorization periods, you're trying to show progress and saying, hey, we only met 30% of what we said. I mean, that's a pretty tough number to show and demonstrate that you are being effective. So it, like the listener, the concern they have over that number and the fact that, they want to get that number higher, they definitely should be striving for systems to do that. And I'd really encourage them to try to look at their 6 month time frame and then break it out into monthly chunks. This month we're going to get to here. Next month we're going to get to here, and they should see improvement in those areas. We have some program managers that will get 100%, of their every month. They're hitting 100%. So and at the end of their authorization period, they've hit every single one of their goal areas, and they didn't set the bar low, right? So there's other ways to kind of in the scorecard system to account for that. You can't just set the bar low, and none of our guys do. I mean, they really want to push the learners as far as possible. So you have that pressure to kind of allow for that as well.
All right, great. Thanks, Tim. That's going to be really helpful for Sean. So let's shift gears here a little bit and talk about supervision. As you mentioned earlier, you recently published an article. You published an article a while back in Behavior Analysis and Practice about the unique model of supervision that you guys have there at Little Star. And you mentioned the term apprentice earlier in our discussion. So let's take a little bit of time and tell us a little bit about this model that you've developed, and so we can kind of learn aspects of it that may be helpful in our practice as supervisors out there in the field.
Yeah, those that are going to be at the Behavior Analyst Leadership Conference, BALC, it's in Connecticut. I think it's March 13th, maybe. It's coming up. It's right around the corner. I'm actually going to do an hour there on our apprenticeship model, kind of take a little bit of a deeper dive. Everyone, the treatment planning webinars, workshops we do and webinars, I mean, everyone just raves over those. This apprenticeship model has been just well received. I mean, it kind of really resonates with behavior analysts. So supervision is a term that's getting so convoluted and so complicated. In fact, it's even caused us problems on the billing side, right? Because for the most part, when you look at, this is my impression, I don't work for the BACB, but when you're seeing kind of discussion about supervision, it's usually being tied to fieldwork experience, right? Mm-hmm. So all the criteria and recommendations that are coming down from the board, even though the board did a really wonderful document on how to work with healthcare, and they have the healthcare guidelines document that they did. It was a fabulous document. I'd point all your listeners to that they can get through the BACB website that really maps out industry standards and is just a great educational tool for getting to understand this idea of working with insurance companies. In there, they'll talk about clinical oversight kind of guidelines. And that's where, instead of supervision, when we talk about, because even when others are talking about billing for services, they'll talk about supervision, right? And so they'll say, I'm in providing supervision hours when I'm in there observing face-to-face with clients and a lot of things. But we like to talk about that as clinical oversight or clinical direction. And I would encourage people to use that language when it comes to that, because we've had insurance companies that are making recommendations on how much clinical direction hours you should do based on supervision guidelines that are mapped out through the BACB as it's tied to fieldwork. So just a quick kind of little segue there on some of the complications. And we, on the fieldwork experience side, we were encountering a lot of pain amongst the behavior analysts at Little Star. In fact, when we were out, we would go out kind of across the country, go to Florida State University, Western Michigan, and recruit BCBAs, because there's just amazing, talented BCBAs coming out of those programs. I mean, so, and it wasn't uncommon to really see that when people are asking, when new grads were asking if they were going to have to provide supervision, right? And it wasn't excited to provide supervision. They were really seeing it as something that they were almost kind of being encouraged, to maybe not immediately take on, right? I mean, that it's in line with even what we're seeing through the recent newsletter from the BACB, is that you got to develop some skills kind of initially before you're having to provide supervision. And supervision, fieldwork experience, when you're supervising fieldwork experience, it can be very, very demanding, right? And what that meant for everybody, what it meant from a supervisee, what am I expecting of you, Matt? If you're going to be my supervisor, you're going to provide my fieldwork supervision. What should I be expecting from you, right? And then you, Matt, for Tim, if I'm supervising you, this is what you should be expecting from me. This is what I'm going to provide for you. And a lot of times that wasn't the same, right? So what somebody's maybe expecting that they're going to get from their experience, and what the supervisor is expecting to provide, wouldn't connect or line up really nicely. And some supervisors felt like it was their job to teach all aspects of the task list, right? So they were going to go through, as part of their fieldwork experience, they were just going to create PowerPoints. They're going to have these wonderful kind of trainings and opportunities to work with their fieldwork person, their supervisee, to cover all aspects of the task list. And pretty quickly, that person would be like, well, how can I do that when I have all of these other things that I have to do as well? And how can I do that when I have 8 different people that are in fieldwork experience, that are in multiple different stages of fieldwork experience, right? And so what we found is that it was a very difficult model for us to just provide fieldwork experience for everybody. It was very difficult for us to be able to make sure that we're providing meaningful fieldwork experience opportunities for everyone. So what we revisited this idea, and we looked closely at what is expected for a fieldwork supervisor. What is what are the expectations that are mapped out by the board, and how we interpret them. Again, this is my interpretation entirely. And how can we meet that criteria and work on developing the level of expertise and knowledge to be effective as a behavior analyst at Little Star. And so that's where the apprenticeship model came in, right? So what I'm teaching you, so if you're Matt, you're my supervisee, what I'm going to teach you is how to be a good behavior analyst here. I'm going to teach you the concepts and principles related to being a good behavior analyst here. I'm going to walk you through what it means to write treatment plans, what it means to develop meaningful acquisition programs, how to do decel programs for this population. And it may be a specialized population. You may be working with learners that are 3 to 7. You may be working with learners that are 7 to 13, maybe over 13, right? So there could be even a specialization area that I'm going to focus on. But all areas of the task list is not my responsibility. So that's a coursework responsibility that you need to make sure that you're getting through your coursework. My job is I want to get you a good, meaningful fieldwork experience here. So what we developed is we call it our Program Manager Apprentice Competency Checklist. So we looked at, for the positions that you have, what does it take to be a good behavior analyst with that population, with that group? And that competency checklist is PMAs are working through their experience as the apprentice is working through. We're kind of checking off that they've met all of those competencies. So it's just a checklist that we can work through to see how they're meeting all those competencies. The other piece that works really great from an apprenticeship kind of model is when I'm a behavior analyst, and this is something kind of unique that on the educational side, I don't know if you have to really encounter, is this idea of the services that I'm providing, they have to be direct. If I'm going to bill for them, they have to be face-to-face. That's the only services that I can primarily bill for. There's some insurance companies, it's getting to be less and less, and in this part of the country that I'm in, other parts of the country have a little bit more success, but where it's less and less where you can bill for any kind of indirect work. So if you're graphing, analyzing graphs, reviewing literature to develop protocols, training, any of that stuff is not a billable service. But all of those are very meaningful fieldwork experience activities, right? So I can defer a lot of those to my apprentice to be working on and developing all of those, which are super meaningful fieldwork experience opportunities. Allows me to still provide these services and be able to understand that they're non-billable, but I'm out and able to still do a lot of the billable work. And while I'm doing the billable work, I have you with me a lot of times, the apprentice. So we're together looking at this learner. I'm conducting my observations and my analysis. I want to get your observations and analysis and helping to even cultivate that skill set, so you can do meaningful observations. You can be able to track progress, be able to catch when you're off progress kind of early, reset the treatment plan, make sure that you're able to meet those goals and objectives like we were mapping out earlier, and all of those core skill sets. But we summarize those, and that's what the apprenticeship model is focused on. Is I'm going to work to develop you as to be an effective behavior analyst in this setting.
I see. So it's not trying to be all things to all people. I wonder at times if we fast forward, I don't know, a decade or two in our very young field, what supervision or, post class work, whatever it'll be at that time will look like. I have a friend of mine, excuse me, I have a friend of mine who's a doctor, medical doctor, and he went to Dartmouth College, medical college, not too far from where I am right now, and he did all these rotations and things like that, and it was, it just kind of makes me wonder, like, where we will mature as a field with those sorts of things. Yeah. So and it and of course, medical training has its own set of problems that we probably don't want to iterate, of course. Yeah. But it seemed like he got a very robust background based on his descriptions of doing a rotation here, a rotation there, and all these different specialty areas and things like that. It just makes me curious in terms of how things will play out in the kind of mid to long term in our field.
It is interesting because the idea then is that you get spread a little bit on your experience, right? You're going to just develop a little bit of an understanding of each of these different specialty areas versus really immersing yourself in this one kind of specialty area, right? So if you're going to have a more general kind of model, then it would be those type of things. And there are definitely a lot of people who argue, being able to do maybe some work with a very different population altogether, being kind of forced to have these experiences. But what we see and what we kept encountering, which is another reason why we developed the apprenticeship model, is that people were coming to us and didn't have the experience, the expertise they needed to be able to work with this population. So we were having to try to develop that skill set. But now what we can do is organically grow behavior analysts into these positions, and they're having this key kind of core skill set that allows us to, I mean, we're almost entirely grown organically now. Like we're not recruiting at all, pretty much have stopped all recruiting efforts and just grow all of our behavior analysts and have a situation where, you can run into where you have, too many and not enough positions, and where you're going to have people that are going to go out and work for competitors. And again, we understood that when we developed this model. It's always a hard pill to swallow when you have this, brilliant expert that you kind of have helped cultivate, and they go on and work for competitors. But we're getting good behavior analysts out there, so it's something that we're proud of.
I see. The idea of not recruiting, I'm sure many listeners who are running clinics and or agencies in general probably would be quite enviable of that position. So
yeah, and it's a unique thing too, because when you get into an apprenticeship, it's a highly competitive slot, right? Because like I said, we used to provide experience for everybody, but now we will provide the first part, which is your direct. So when you're doing the 1,500 hours of fieldwork experience, 750 is direct, or up to 750. I mean, it can't exceed 750. So the way we've structured our model, that first 750 you're getting in direct, so you're working as a technician. We're going out, giving you feedback and helping to get you to really understand the technician role. So we see it essential to be a good behavior analyst in this space. You have to have worked through the technician part and really understood what it means to be a good technician, because you're going to be, you need to have that kind of empathy and that core skill set to be able to kind of work with that group. And now in the second 750, you get into the indirect. So now you're no longer working as a technician. You have to, that second 750, and it takes a year to still do that second 750. You have to compete for those slots. And then you are only in that slot until you complete your BCBA, right? So, and then you have to get out of that lane, and then somebody else gets into that slot. So it's a temporary position that you kind of go into until you achieve the BCBA. So logistically, there are some pieces that you'll just have to kind of work with each of your individual models. But we found it to work really, really beneficial. And even though they're unbillable that whole year, it allows the BCBA to be more billable. So we found it as a fiscally positive, revenue positive kind of movement as well, to create these unbillable positions and move to this model.
Yeah, I could see how someone laying the groundwork for the certified clinician doing the work would be a force multiplier in many respects.
Mm-hmm.
All right, cool. So another listener question related to supervision. Let's see. Chris Tullis writes, "Hey, Matt, I wanted to shoot you a couple of questions for Tim." Well, thanks, Chris, for writing in. I appreciate it. Let's see. Number one, have you seen supervision practices evolve over time? And do you have any reservations about specific types of modalities, for example, distance or in person? Number two, well, I'll go through the rest of them, so let's just take them one at a time. So what's your thoughts on the supervision evolving over time, certainly given the perspective of being in the field for a little bit?
Yeah.
More than a little bit, I should say.
We had a radical shift in our perspective on it, for sure. As we moved to apprenticeship, there was a key shift for us in the field, really seeing this idea of, and I still think just in general, the field needs to come to an agreement. Like, is it the fieldwork responsibility to cover all areas of the task list? And again, like, it's my interpretation, that's not the case. But you see some university programs, I've heard people talk about it from university programs, that, even if we don't get to something in the task list through our coursework, well, that'll be covered by the supervisor and fieldwork experience, right? The supervisor's kind of a stopgap.
That's an assumption. That's a scary assumption.
I agree. And I think it's those type of pressures that people are like, I don't want to do supervision, right? If I'm going to be expected to cover all areas of the task list, that's not something that I can do. Definitely this idea of remote. I feel like as long back as I can remember, I've been doing remote supervision. I do it kind of privately for people when they can't find someone, for all over the country. I've been able to help people, Guam, Ireland, others where they just can't get access to a behavior analyst, and so to help them through remote supervision, it's not as ideal, for sure. I think there's ways to do it. Getting video and being able to provide feedback on video allows you to to equate and kind of be able to replicate, some aspects of a meaningful fieldwork experience. But it definitely is hard to compete with being able to be right there with you, getting your feedback right in real time. I think there can be some challenges to that model, but I get why it has to exist, right? I mean, there just are not enough behavior analysts currently to be able to. And the last thing we want to do is have any kind of log jams and where people aren't going to become behavior analysts because they can never get fieldwork experience. And so the remote supervision model kind of is definitely a necessity.
So let me ask a follow-up to Chris's question on that specific topic. Is there one tip that you found helpful, whether it's if it's just a technological tool or some other thing that makes doing supervision in a remote manner more successful?
Yeah, I on the tool side, I love Dropbox. Really love getting people kind of up to speed real quick with Dropbox and be able to share documents, share articles, share, so you can kind of share back and forth. Really very easy. On the video sharing part, I mean, there are ways to share privately through YouTube kind of videos and making sure that you get the appropriate consents, et cetera. But I've definitely found YouTube to be a good tool for just privately sharing videos, so that, and I imagine it's not the most secure, safest way to do it, but there are definitely ways in which you can kind of share those videos kind of back and forth. But, those are the some of the pieces that for me personally is in doing remote supervision, I found to be kind of some of the most helpful components of so that you can still kind of provide feedback on video, share those videos, have access to documents, be able to share documents. Google Docs is another great kind of tool for collaborative kind of writing of behavior plans and treatment plans, et cetera. So,
all right, neat. He also writes, given that the field is growing rapidly, what steps should be taken to ensure that new practitioners have time to actually develop their supervision practices?
Yeah, this is another one that was really pretty key for us in developing this apprenticeship model. So the cool thing is you're an apprentice, you're working with a supervisor. So that supervisor is now modeling the skills that you'll need to use when you move into being a supervisor, right? And so the other part that's kind of neat is that, as the board is kind of now mapping out some expectations that you've been practicing for a while, you're under the supervision of somebody else. And so that you can kind of further have this opportunity for now, I'm going to spend some time mentoring and developing you as a supervisor of an apprentice, right? And so you can develop, really sharing with this person, I want to help you develop my craft. This is my craft as a behavior analyst. And I want to, take you under my wing. I'm going to help you develop it. And this is, how do you appropriately do that? How do you still leverage that person so that you can still be effective in the work that you're doing? So it's not working against you, it's working for you, and it's still helping to develop that person into an effective supervisor.
And kind of a related question. So when pursuing supervision, what should people be looking for, as a trainee, whether it's a facility, a specific supervisor, attributes of someone, and what type of overall experiences have you seen that lead to a successful supervision experience?
And one piece that I definitely would love to see more is just interviewing your supervisor, right? So trying to find out, hey, walk me through your experience and kind of what areas have allowed you to kind of develop the competency necessary to supervise me, right? You could word that in a way that's going to be much nicer and friendlier, but the goal would be, hey, I just want to understand, your expertise and kind of how you'd be able to help me as a supervisee. So getting somebody even at the, walk me through your CV and your experience, and spending that time initially sharing, and even on the supervisor side, establish this is how I've identified this expertise. This was my path. This is how these are the areas that I feel competent to help you in, right? So, which is another wonderful part of the apprenticeship model, is that we define those this is my scope. This is the area that I am competent to provide your experience. So you understand that these are the areas. And if there are other areas that you needed to develop some competency, well, we could see internally if we have somebody, but But if we don't, those are areas that you would have to kind of seek outside consultation. I could help you to do that. We could help you to find those people. But, these are the areas that I feel competent. And so the ethics code kind of requires that, but it's something that you should have that discussion kind of early on. It should be encouraged. You should want the supervisor to say, hey, this is how I'm competent to provide supervision for you. But, if you're not getting that, if I was new, I would want to understand what is my experience going to look like? Can you walk me through and help me understand, what exactly is my experience going to be like with you, right? So organization or supervisor. So we can walk you through exactly what the apprenticeship model is. This is exactly how it works. It's completely transparent. It's completely upfront. Every bit of it is, right? We want people to have a true understanding. This is what your experience is going to be like if you're here, if you're working through the apprenticeship. There are definitely, I have still hear kind of rumblings and would wonder where people are just kind of signing off every week and there's nothing meaningful about that experience, right? So if you're just doing work and you're just having a signature and that's your fieldwork experience, I would really, really try to make sure to stay away from those. If you're seeing an early pattern of that, I'd really advocate for yourself. This is your opportunity to develop your core competencies as a behavior analyst. This is really kind of push for and make sure that you're getting that meaningful experience. If you're not, I would look to go to other places. So, and if people can't really explain to you what the experience is going to be like, what you can expect from your supervisor, that would be a flag for me. I would really look to kind of get away from those type of situations. But interview your supervisor, really push to get an understanding of what experience is really going to look like. And, those would be the key pieces that I would look for and really start having some concerns when it's just signatures.
Yeah, for sure. I've heard some horror stories at times of things like that. People just signing off in a perfunctory manner and not doing due diligence as it relates to providing supervision. So, but that was great advice. And I think on the supervisor end, it might be worthwhile kind of putting maybe some of those thoughts down on paper of what are those things that you feel really comfortable with providing, excellent mentorship in, and what are those things conversely that, you want to be transparent with your trainee about things that you're not strong in, because, obviously nobody is, going to be, you can't be an expert in everything, especially Absolutely. Given the nature of the expanding task list. That's good stuff, Tim. Thanks for sharing those thoughts. So we've been chatting for a while here. I've got two more questions for you. One is a selfish question, kind of. So you, as you mentioned, you go around doing a lot of presenting and things like that. And I met you, I think it was at either APBA or ABA, or one of those two. And the first thing that was struck me immediately is that you were wearing this impeccably tailored suit. And then the second time I saw you, you wore something else. I can't remember it, but it was, it's like, wow, this guy got it, has his wardrobe game, pretty strong here. And so it just as a selfish question, this is probably half the listeners are probably looking for another podcast, or actually more than half the listeners, given the demographic nature of our audience. But stick with me here for a second. This might go somewhere. Maybe not. We'll see. But anyway, what are some from you? So given that you have expertise in this area as well, so what are some I guess fashion fails that you see as you're out at conferences? I guess where I'm going here is, can you help us dudes out who perhaps are not as attuned to these issues as someone like yourself? What are some common mistakes you see, and what are some ways in which when we're going to conferences and things like that, we can put our best foot forward from an appearance standpoint?
I cannot recommend enough, even if you get a suit off the rack, having it tailored, and just going to a good tailor, developing a relationship with a good tailor. And you can get a suit from Express, go to a tailor, and it'll look custom. right? I mean, you can really go a long way just with a little bit of adjustment here. I really like a tapered leg, you know what I mean, versus a really loose kind of leg, and where the pant is a little bit too long. All of those just a little bit too long, and you look frumpy, and you look, but if you have it cut a little bit tight on the tapered leg, showing a little sock, you know what I mean, that can go just a long ways. Little teeny things who just can make a bit, and then still understanding colors of sock, how you're going to make that kind of tie into maybe your shirt color or a pocket square, making, really having some thought in how your whole kind of ensemble is going to work together. I'm really fortunate in Indiana. There's I work with a clothier, and if I had an infinite amount of resources, I would be to him all the time, and he's just amazing. But he helps me a lot with kind of how to structure, and how to set colors and how to balance. And he gets a sense for my style. I like more dramatic stuff. I don't like really very plain, kind of like to be bold, and I think guys shouldn't be afraid to be bold. They shouldn't be afraid to kind of throw out and use some fun colors. I have red pants. I love wearing red pants, and I've gotten lots of feedback about, wow, you're wearing red pants. That's cool. And just really, really wild kind of shirts that are, that just are a nice kind of good fit. Spending some time just making sure that you have a good fit, I think is a really, really important piece. The bold part, just not being afraid to kind of throw yourself out there and do some kind of funky. The cool thing is, you see all suits, everything really trending towards more and more kind of funky, bold stuff, which is super cool. Those are, I think, the main kind of fails I see is just kind of, not having a good fit, and just, even if you don't have to be in the best shape, even if and I probably, maybe the worst shape you're in would be the more importantly to have a good fit to your suit, right? To make sure that it's fit to kind of help accentuate your positives and kind of help in some of those areas. But the other piece that I can't recommend enough is, and this was a painful process for me, painful process, is to learn how to tie a bow tie, right? So I have probably the number one praise that I get is just wearing a bow tie. And, so they just are such a bold statement, and you can't clip on, like it's not the same thing, but and I've been at conferences for presenting, and I'm in this T-Rex, like my arms almost froze in this T-Rex like lock up, because I've been having to retie my bow tie to get it locked in. But it's having a strong bow tie game, I think, is another really key piece to fashion. But I could talk all day about this. This is something
I know it's a passion of yours, so I just wanted to give you the opportunity to talk about it. It's obviously something that I think people know you for. So I want to just take a moment to have you help us fellas out who struggle in this area. Usually I kind of rock the I kind of remind myself of like the vice president, the vice principal of my high school, and I know I could do a lot better. So yeah. So anyway, all right. So all kidding aside, our funny business aside, let's close with the final question here. So, and this is probably something that you're very familiar with, given the amount of supervision that you do. So, what advice would you impart to a newly minted BCBA? So someone just finished their supervision, they banged out the exam, and they're at their first job, whether at Little Star or elsewhere. What is a piece of advice that you would leave them with?
I just can't. I think a key strategy for my success, something that's been really helpful for me, is just to be humble, right? I mean, it's just, you do not know everything. You're not expected to know everything, and have a continuous learning kind of model, right? You're just always learning, right? And it's, you're never happy and with just, here's the status quo, never, it kind of leading with this model where, you kind of know everything, and you want to kind of have that kind of approach. I mean, so be super humble. I would always focus on continuing to learn, right? I mean, I'm never going to stop learning, whether it's how to DJ, whether it's how to do CrossFit or jujitsu or, behavior analysis, I mean, I am trying to learn constantly. So, I mean, I refuse to kind of stop, I feel like it's a core to thriving as a human, is to have this constant kind of learning approach, which is why I love podcasts and, love discussions like these, so it kind of pushes you to see what you understand and don't understand. But I would I can't encourage enough, just a humble model, a model where you're not afraid to tell somebody, I'm not quite sure I understand that. Or, even in the moment, there's some people, I'm around brilliant people all the time and they're saying things and I'm like, gosh, I hate to admit it, but I don't understand anything you just said. Can you really help me kind of walk through that? I want to understand this. And historically, I just would have nodded my head or kind of looked like I understood, or I would have said something where I'm totally willing at this point. I wish going back, I would have been willing more often to say, I don't understand that. No, I'm not quite sure. Can you help me? Can you help clarify? Can you help me kind of understand that more? Or being very honest and saying, this is something I'm really weak at, and being able to tell somebody who, you really admire and respect and say, hey, this is something I'm weak at. Can you help me develop? And if you encounter somebody, which would be another good test for supervision, is saying to somebody, hey, I'm really weak in this. Can you help me? And if you get some kind of response like, no, I'm not going to help you, that's probably not a good person that you want as a mentor or a supervisor, somebody that you want to attach yourself to. So, that would be my kind of key takeaways. I mean, we're really fortunate in this field. We all want to help each other be better, and we all want to, we're all really dedicated to the science of behavior analysis and understand, in order for us to be really effective as a field, and even our weakest links have to be really, really strong. So I've been so impressed, everybody, that how open they are to really offering advice and assistance. And, but yeah, that would be my kind of thoughts.
All right, great. Well, those are very wise words to end on. Tim, thank you so much for joining me today. I know this episode is going to generate a ton of follow-up questions, and certainly we left lots of meat on the bones. So let's just look forward to having you back for round 2.
Oh, I'd love to. Absolutely love to. Really, really enjoyed it.
Hey, everyone, you thought we were done, but it turns out we forgot to bring up something that Tim really wanted to impart to you. So we are going to do an addendum to this interview. So, Tim, I know that you've worked with Denny Reed about supervising behavioral technicians and things like that. And so why don't you go ahead? It's something that you really want to make sure that the audience heard. So why don't you go ahead and tell us about that?
Yeah, this was another project that we were developed internally. We kind of found another real pain point that behavior analysts were having as they were kind of newly minted and started, was this, how do I supervise behavior technicians? And behavior technicians were having also a lot of problems with, developing relationships and certain leadership styles or management styles that were being exhibited by behavior analysts was ruffling and kind of developing some friction amongst that relationship between the behavior technician and behavior analyst. And that's just an imperative relationship. I mean, it's so important for good clinical outcomes, is to make sure you have a really meaningful relationship between behavior analysts and behavior technicians. So we got with Denny Reed, and Denny Reed is just a nationally recognized expert on training and how to develop skill sets in paraprofessionals. And he's done just amazing trainings on that, and his work on happiness is just fabulous. So, but he's on our advisory board, which would be another kind of cool thing we could talk about at some point, is kind of working with advisory boards. And we were discussing this with him, and he helped us create this curriculum that you can access through Sloan, and probably in the presentation, right? Yeah, show notes. We can kind of link to the curriculum, so you can take a good look at it. But what it allows to do, so in the board, in order to become a supervisor, you have to do that 8 hours of training. So, and what we found is most of the training opportunities for that was, again, how to supervise fieldwork experience. And we didn't want to develop the fieldwork experience repertoire. What we were looking to develop is the how to be a good supervisor, how to be a good manager repertoire. So this curriculum, it creates that 8 hours. It allows to It's structured in such a way that you can get that 8 hours done, and you can still focus on developing these managerial skills amongst behavior analysts, which we're still seeing. Most programs, where they're coming from, is that's an area that's not hit on. It's not typically hit on in fieldwork experience. It's something that we are developing in our PMA model. They actually will go through the curriculum that we put together with Denny Reed. So it's a model that we put together through with the videos. It has a video segment that goes along with it. Those videos will be available through the Cambridge Center. We're going to have those uploaded there pretty soon. Probably in the next month or so, you'll be able to access those through the Behavior Center, but behavior.org, through the Cambridge Center. But those are, I mean, it was again another kind of real core area of development that we saw that new behavior analysts were needing, is just how to become good field work, good supervisors, and how to really be effective at supervising behavior technicians. So it kind of even ties into the earlier kind of discussion about, what are good ways to develop new BCBAs, and advice for newly minted BCBAs is to really focus on being a good manager, because every position I've ever had as a behavior technician, I've had to manage somebody.
Of course, yeah.
One person or 20 people, or now, maybe having around 150, 200 people indirectly reporting. So it is just a core skill set. Having a curriculum like this, or an opportunity to develop that, was something that we found pretty important for our behavior analysts internally, and we're really proud of the curriculum.
Awesome. Thanks for sticking around to add that, and we will have those links, etc., in the show notes. So again, thanks for joining us. This is a goodbye for reals. So Tim, again, we will look forward to having you back on the show. Thanks for joining me today.
Awesome. Thanks.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations, and on Twitter at Behavior Podcast.